So, thank you for turning on the recording. Good afternoon, everyone. My name is Shamia or Mia. I am the Acting Viral Hepatitis Program Director with the Tennessee Department of Health, and really excited to have everyone join us today. I hope that joining the session was really easy. It should just be a click of a button, join session, but we'll walk through some of those things later today. So thank you for joining us. Next slide. So we are going to start with some brief introductions and announcements, and then a didactic presentation by Dr. Chastain on treating hepatitis C virus in the setting of HIV co-infection, and then a case presentation and some question and answer time for question and answers, and as well as hot topics. First, starting with some in-chat introductions. Next slide. If you will share your name and organization and your role and whether or not this is your first ECHO session, that would be great. You can put it in the chat. Also, I'm really curious to know how much snow everybody got, so you're welcome to share. And if you had any issues with joining today, we are always welcoming feedback, so let me know. Yes, and thank you, Anastasia. If you all are having any technical difficulties or anything, please don't hesitate to reach out to Anastasia, and she should be able to assist. All right, see people putting introduction in, it's great. Dr. Chastain says also 8 inches of snow. That is quite a bit. So you can continue introducing yourselves. We're happy to have everyone. We will get started first with hot topics. So those of you that joined us at our last 2023 session might recall that we have introduced a hot topics space to be able to just ask questions related to viral hepatitis that maybe we don't bring up otherwise. So this is an open forum to go ahead and ask those questions now. Anybody want to get us started with something that's been on their mind? They'd love to ask our subject matter experts and other colleagues on the phone that might have experience. We're getting better at awkward pauses, guys. So. I think last time we had some questions related to harm reduction as well as different labs and kind of interpreting some of those. Some interesting kind of points brought up there. Anyone want to add to that or have questions, related questions? Or something that you have come across recently that you found really intriguing, whether it was an article or experience in your own clinic?
Yeah, I have a question.
Go ahead.
So we have been seeing an odd test sequence that we have not seen before, where we have a positive antibody followed by a negative antibody, and then lastly a positive antibody. And this is like, within a couple of years. So we're kind of ruling it out as potentially not a false positive, but we were wondering if any of the experts had any idea of why we're seeing this weird sequence.
Kimber, do you mind saying a little bit more as far as the time between the positive tests and also whether these were routine screening tests or part of some other surveillance measure?
I can get better data to narrow it down for you. As far as the timeline, we've seen a lot of them recently, but we have seen like it'll be like years in between. So if it's years in between of a negative going to positive, we know that we understand that, but we're confused on the positive going to negative. I can look into it more and maybe have some more information for you as far as if it's a routine screen and why the client's being tested.
It's okay. I was just asking for more clarity. Uh, I would first of all affirm that what you're describing is odds. Typically, what we think about as far as immune activity as it pertains to hepatitis C is that uh, a antibody test is really a serologic marker of B cell immunity. Basically, a virus as a foreign entity is presented to the immune system. The immune system reacts to it, and that the immune system typically will maintain marker of prior exposure lifelong thereafter. Uh, Typically, once we see a positive hepatitis C antibody test, we presume that that test will be positive for the rest of someone's life, and it simply is a marker of exposure, not necessarily a marker of active infection, as we've discussed in this context previously. That being said, there are a variety of reasons why a antibody test might be positive in a person and their later be a negative response. That could be waning immunity, whether it be due to a specific pathogen like hepatitis C, or immunosuppression, medications that potentially are administered to a person to weaken their immune system for a cancer, a rheumatologic condition, dermatologic condition, or others. And a person who had previously had a positive antibody may subsequently have a negative antibody at a later time if there's something that's changed as far as their immunologic function. We don't typically think of that occurring frequently with hepatitis C. And indeed, in most of my patients who are immune compromised, I would actually expect that their antibody would return positive on subsequent tests. We also do recognize that there is some aspect to waning immunity over time. We recognize this in specific populations, such as people who have gotten hepatitis B vaccination may have a waning response to that vaccine over time and might have a positive hepatitis B surface antibody repeatedly, but then 5 years later, or 10 years later, 20 years later, no longer have a protective response. So there is potentially waning immunity that can occur. That is an potentially multiple different explanations beyond just a laboratory error of why a test might go from positive to negative. Going from positive to positive again would infer that either something about the test has changed, something has changed as far as the immunologic function of that individual, or that there was waning immune response and then a re-exposure. This is actually much more problematic from a surveillance context about how to interpret these than actually it is in clinical practice. In clinical practice, when someone has a positive hepatitis C test, we follow to see if they've got active infection and we act on that. And then in the future, if someone is exposed again, we screen and we can jump directly to RNA or nucleic acid testing to actually clinically determine whether someone has active infection or not. From a surveillance standpoint, much more problematic as far as how to define this. And it's a great question, but that's a very long-winded answer of saying, first, affirming that going from positive to negative to positive is weird, that there are multiple explanations that are related to the host, their immune system time, or the test, particularly false positive or negative test that could explain a test going from positive to negative. Going from positive, negative to positive basically compounds that one additional layer because then you have to make an explanation of why there was something different in the interval. I would certainly welcome Dr. Allen or Dr. Alfaro Cruz if they've got different opinions or additional opinions, but that's definitely a weird one.
So that is really interesting. I really appreciate that you brought up too, like how it can change depending on immunosuppression and such, and also I wonder how much plays a role in like some labs have different reference ranges and such as well, and if that could play a role. I think we've had maybe we've touched on this a little bit in the past, but and Kimber, I think that there's been some questions related to pregnancy, whether or not that's playing a role in some of these as well. As am I remembering that correctly? Yeah, I see your head nodding. Any
So
additional things to add to that?
yeah, well, so I will jump in the two framing things that I thought you have brought me that are really important, and then to jump off that last point. First of all, I think it's really important to recognize that when we talk about negative and positive tests, those cutoffs are determined by either the laboratory or another setting, and that typically means the intensity of the antibody response based on whatever laboratory parameter. There are some laboratories that might say that a quote unquote 10 is a positive, or another laboratory might say a 4 is positive. And if someone is in that interval range of 4, 5, 6, 7, it might be determined as an indeterminate test or a negative test on one laboratory profile versus one that's positive on another. So actually ensuring that we're comparing apples to apples and that we aren't just having a different interpretation on the qualitative front is actually really important. The latter is also really also important reflection is that pregnancy is a very unique construct when it comes to immune function. Pregnancy in one sense could also be considered an adapted immune state because when a woman is pregnant, then the immune system does change to accommodate the presence of another human being interfacing with that same immunologic space, and that can lead to sometimes changes. There's also some groups that have proposed that there might be a different false positivity rate in women who are pregnant. I don't think that there is robust data to demonstrate that we should have different parameters or different perspectives on that. But I do know anecdotally that there are different providers who have screened populations of pregnant persons who feel like that there are different positive antibody to negative RNA rates among those groups, as well as have observed different antibody responses both pre and during pregnancy. Again, I don't think that is anecdotal. I don't think that there's robust data to actually dictate that. And I think that as we are currently in the space where all pregnant persons are recommended to have hepatitis C screening, I think that is absolutely still what we should be doing. I think that there are some unique cases around the margin about how we counsel and how we monitor and how we care for people. So I don't want anybody to walk away from this and say, well, Dr. Chastain said that we don't need to screen during pregnancy because it might not be accurate, because that's not what I want to infer. I do think that pregnancy has its own unique characteristics as far as immune function. There might be specific cases that might be impacted as far as positive or negative test in that context. And that if you all are observing from a surveillance standpoint, differences like this, actually pulling that data out and trying to get more clinical context for those might be helpful in trying to elucidate what those differences are.
Yeah, I really appreciate that you brought that up too. There is definitely a difference between clinical kind of side of it and surveillance side, and a lot of requesting medical records and such. So really interesting components. I see Dr. Alfaro Cruz put in here. I have a question regarding changes in insurance. I have been having more issues regarding insurance approving 12 weeks of treatment for Harvoni. Has anyone else encountered this recently? Anyone want to speak up to that?
Yeah, I'll speak up. From a pharmacist perspective, I have several insurances that I've run into that have completely removed Harvoni, Ledipsir, Cefosivir from their formularies and just have strictly preferred Cefosivir, Velpatasvir, trade name Epclusa only. Also have the same type of scenario with Glucapavir, Piprintisvir, trade name Mavyret as well. So it's I've noticed a lot of insurances recently have narrowed their formulary to just one agent, which can be very limiting from when there's drug interactions available or present. It's caused issues for me having to do more reconsiderations or appeals or peer-to-peers to get proper medication approved when there are restrictions to using Cefosivir or Velpatasvir in those patients. So I've definitely experienced that. They're trying to narrow their scope, I guess, for money purposes. That's usually the root of things, but it does make it complicated when there are factors that would steer you away from using the pangenotypic cephalosporin hepatosphere. So I can agree that there are issues with that. I do my best to let them see it my way from a clinical perspective, but sometimes it's hard to get to a clinical person to see the clinical perspective of it to get it approved, the correct medication. In your patient's case, probably Harvoni is probably a more preferred agent depending on drug interactions or genotype or other type of issues. What was your specific reason of why you needed to use that, Dr. Alfaro Cruz?
I think mostly the presentation too, kind of benefits, and we were trying to get that on board too, with being pan-genotype, but mostly the issue that it was easier for the patient to take with the beads. So, and it has been something new because literally at the beginning of the year last year, we were not having any issues and we were able to prescribe. I've had other issues where patients had failed to a first line medication, then we have had to retreat them, but they don't want to do the full course of the medication. So we got briefly in trouble because the insurance would not approve and the patient had a lack of receiving the treatment for about 5 days. And we'll submit that case hopefully soon so we can discuss about that. But definitely it has been a lot of changes over the last couple of months, I would say, that I've been noticing these becoming more and more an issue.
Yeah, thanks for bringing that up. That's interesting. That sounds like something that'll be brought up again soon. Well, feel free to continue putting questions and such in the chat. As we have time, we will be answering those as well. In the interest of time, I think we will go ahead and move forward with our presentation from Dr. Chastain. So I will turn it over to you. Go ahead.
All right. So this won't take as long as this small talk used to take. I'm going to speak about treating hepatitis C virus and saying the HIV co-infection, recognizing that many of you may care for people with viral hepatitis as well as people with HIV, and also recognize that any public health intervention, when we're thinking about syndemics, also need to incorporate what is safe and effective as far as different treatments for these populations. Next slide, please. I don't have any pertinent financial disclosures or conflicts of interest. Next slide, please. And so at the end of this brief session, I hope you'll be able to describe the benefits of treating hepatitis C in people with HIV, that you'll be able to identify important drug-drug interactions between HIV and hepatitis C antiviral medications, and then get practice of selecting appropriate hepatitis C treatment options in people with HIV. Next slide, please. So this is a brief outline about how I'm going to navigate this. I'm first going to focus on what we know about the impact of HIV-HCV co-infection on clinical outcomes. Basically, what's different if you have a person with HIV and hepatitis C compared to someone who just has hepatitis C as far as what we expect for their health overall. Second thing I'll focus in on is the efficacy and impact of treatment. How does the impact of hepatitis C treatment differ in people who are co-infected versus people who just have hepatitis C? And then the last section kind of blended together. How do we navigate drug-drug interactions and selecting hepatitis C therapy in people with co-infection? Next slide, please. So this is a little bit old as far as from a data standpoint, but I think it makes the point still, is that about 25% of people living with or people with HIV in the United States also have hepatitis C infection. This was at least true prior or in the midst of direct-acting antiviral introduction in the mid-2010s. This means that we have around 3 million people in the United States with hepatitis C. That number's drifted downward with effective treatments and different interventions, but still in the high twos. The number of people with HIV in the United States is a little over 1 million, and you see that overlap. Is that, at least at the time of some of this data in the late mid-2010s, we had about 300,000 people with co-infection. Next slide, please. Two things just to highlight is that liver disease really remains and has remained a significant cause of death among people with HIV. There's a couple different cohorts you can look at this from. This is the DAD cohort. Again, data hasn't really been dramatically updated, partly because of interruptions with COVID. But in 2014, you could say that HIV itself, leading to acquired immune deficiency syndrome, caused the single highest, greatest cause of mortality among people with HIV, followed by cancer, then by liver disease, predominantly driven by viral hepatitis, most commonly hepatitis C, and then by cardiovascular disease. All other cause of death kind of fell into that last bucket. If you move to the next slide, you can also think about non-HIV causes of death among people with HIV, and you can actually cut it not just worldwide, but also focusing on high-income countries. And if you pool non-AIDS cause of death, that is over 50% of cause of death in people with HIV. And actually, by the time that this study was done in 2016, malignancy followed by cardiovascular disease, then very closely followed by liver disease, were the most common non-HIV causes of death. And really what it boils down to saying is that heart disease and cancer are really important in populations, but among people with HIV, liver disease is a disproportionate cause of death. Next slide, please. This is a slide I commonly use and that many of you who have attended other trainings that I've given have seen about talking about HCV natural histories, that only a minority of people with HCV actually develop advanced liver disease. It takes a substantial amount of time for that to occur. However, there are things that accelerate that timeline, and HIV is one of those. And that's really the only reason I have this slide here, is to highlight that HIV itself increases the likelihood and also the speed of moving to advanced liver disease. Next slide, please. These are old studies. One from 2001, one from 2013. When we're talking about data for HIV, what really means that 2001 study was pulling from cohorts of patients who really weren't even effectively treated for HIV. The latter study, published in 2013, still was actually pulling from data during a period of time where some people were not recommended to be taking HIV medicine. So I think this is really a reflection of the natural history of HIV and viral hepatitis, particularly hepatitis C, in an era where we manage HIV differently. But what we can say from these historical studies is that when people were treated, I reframe this, if people have HIV and they were treated with either older therapies or no therapies, what was their risk of developing cirrhosis if they had hepatitis C, or the risk of developing end-stage liver disease as compared to the general population with hepatitis C? And the takeaway from these studies, or these forest plots here, is that the risk of developing cirrhosis if you had HIV and hepatitis C was basically a relative risk of 2 or twice over that of a person who just had hepatitis C. The relative risk of end-stage liver disease was 6 times that of a person just with hepatitis C. Now, I think a lot of this is ameliorated with modern HIV therapies that are more effective, but we actually don't know that conclusively. And so I think it's really important to highlight that the likelihood of progression to cirrhosis and liver failure is substantially higher in people with HIV, particularly if their HIV is not well managed or well controlled. Next slide, please. We also recognize that there are additional factors that among people with HIV and hepatitis C increase the likelihood that they could develop cirrhosis, liver failure, liver cancer. The older the person is, the higher their BMI, the more alcohol they use, the higher the hepatitis C viral load, the higher the HIV viral load, and the lower their CD4 count has ever been. Not just what it is at this moment in time, but ever been. All these correlate with increased risk of fibrosis or disease progression. Next slide, please. So I think I can just conclusively make the case that having HIV and hepatitis C together is worse for liver disease outcomes than just having hepatitis C. So then the next question is, well, how effective is hepatitis C treatment in people with HIV and hepatitis C? Next slide. This is actually a graph that I and Autumn Bagwell, now Autumn Zuckerman, prepared when writing a review article back in 2016. And quite frankly, the data hasn't changed much since then. What I want to highlight is that in the era when we use interferon and ribavirin alone, you can see that the overall sustained virologic response rate among people with HIV and hepatitis C range from 20 to 40%. If you're familiar with other data, that is substantially lower than the 40 to 50% that was generally accepted for pegylated interferon ribavirin for general populations. Then when we move into the era of early direct-acting antivirals, there was dramatic improvements in SVR rate among people with HIV and hepatitis C. But quite frankly, once you move to 2014 and beyond, particularly as you get away from sofosbuvir-only trials, you can see that the cure rate for sofosbuvir-ladipsvir, sofosbuvir-velpatasvir, grazoprevir, elbasvir, as well as glycopyrrolentosvir, which is not pictured in the study, all settle into the low 90 to mid 90s, basically indistinguishable from other clinical trials. Basically, with the modern regimens that we have available for hepatitis C, there is no significant difference in outcome or efficacy or cure rate among people with HIV and hepatitis C co-infection. It used to be that if you had HIV and hepatitis C, I had to tell people that the likelihood of cure with the regimen was lower than if they had hepatitis C alone. That is no longer true. Next slide, please. That really leads into the treatment recommendations today, is that treatment for people with HIV and hepatitis C co-infection, they should be treated and retreated the same as persons without HIV infection, with the caveat after recognizing managing interactions with antiretroviral medications. Next slide, please. I also want to highlight that a lot of you might refer to the simplified guidance, and the simplified guidance being a tool that for people who've never been treated before, who either don't have cirrhosis or do have cirrhosis, that you can treat them using a minimal labs, standardized medications, and a clear follow-up plan. But if you look at the top of these documents, there's a box in red that says who is not eligible for simplified treatment. And actually, if you look at these documents, it'll say HIV or hepatitis B surface antigen positive as being a reason to avoid using the simplified tools. Next slide, please. But I really want to highlight, as we move on to the next slide, that while it says HIV or hepatitis B surface antigen positive on the documents, that's actually no longer true. And if you go into the guidance and into the guidelines, they actually say that HIV is no longer a reason to avoid. So I think I had an animation buried in the slide that just brings a red X over the HIV. So we can move on to the next slide or animate that. I think the main thing I want to really get to here at this point is just to highlight here is that you can use simplified guidance for people with HIV today. This is not a reason to avoid. If you dig deeply into the simplified guidance, I'm sure Dr. Allen would remind us, is that we should address drug-drug interactions for all patients who are going to be treated for hepatitis C, and we need to evaluate for drug-drug interactions regardless of their medications, and we need to assess that. And that's actually true with HIV as well.
We might have lost Dr. Chastain.
I'm here.
Okay. Go ahead.
Half my computer died, but my laptop's still running. So I got that working for us. So can you still hear me?
Yes, we can hear you. Go ahead.
Next slide. We'll carry on. All right. So if we are going to make the argument that hepatitis C is extra bad in people with HIV hepatitis C co-infection, if we're going to make the case that the treatment is just as effective and we should treat everybody, including using simplified guidance, then we just need to tackle what are these drug-drug interactions that we need to monitor or pay attention to. Next slide, please. There is actually a specific section for unique patient populations within the guidance, and there's one that's specifically focused on HIV hepatitis C co-infection. Next slide. And within that section, there is this wonderful graphic. And Mia's sharing a link to that section for us. And this graphic really goes back to Jennifer Kaiser's work at University of Colorado, who is a pharmacist who really did a lot of education around drug-drug interactions early on with the advent of direct-acting antivirals. Her graphics were adopted and adapted by multiple different speakers and experts in different settings, and eventually were updated and adapted into the guidance. But you can see on the left column here, it's a list of some of the most commonly used HIV medications. Across the top row, you see the most commonly used hepatitis C medications. And you see some color coding of A green color, essentially noting no significant drug-drug interactions that would worry us. Yellow, basically having some caution and also some notifications about what happens with medications. And this pink-red color, which is really a concern for significant drug-drug interactions, that while you might be able to adapt around them, generally speaking, there might be other alternatives or better options available. Let's move on to the next slide. So here's my Cliff's Notes version, which will make Dr. Allen gasp at how limited and crass it may be. But if we go ahead and move through here, I think I buried some animations here as well. First of all, HIV protease inhibitors, specifically those who are boosted with ritonavir and cobicistat, cause frequent drug interactions. That's just a true statement, period. Ritonavir, cobicistat, and HIV protease inhibitors, generally speaking, cause lots of drug interactions with lots of prescription medicines. So we need to watch out for that. And a good way to remember is that HIV and hepatitis C protease inhibitors do not mix, which I'll highlight later. The second is recognize that one of our backbone medications, tenofovir disoproxil fumarate, trade name Variad, or half of a trade name Truvada, which many people are familiar with both for HIV prevention as well as a backbone medicine for HIV, is often impacted by some HIV and hepatitis C medicines might boost the availability of that tenofovir, which may warrant some additional renal function monitoring, although real-world monitoring or real-world practices haven't dramatically changed with that therapy. The last animation on this slide is just to highlight that older antiretroviral therapies have not really been studied with direct-acting antiviral therapy. So when I have patients coming in who are on an old medication like nevirapine or zidovudine or other things, this is just a great opportunity to really encourage them to update their antiretroviral therapy. There's a lot of patients who sometimes feel like if it's not broken, they don't want to try to fix it, especially when it comes to a long-standing therapy that's been effective for them. That being said, I would say that a lot of those older HIV medicines have significant adverse effects over the long term, and that this is an opportunity for us to update that, particularly if people are invested in their viral hepatitis care. So the next slide, I believe for us, is just there are more opportunities. HCV guidelines is one I've offered. The AIDS Info or NIH guidelines for HIV care highlights drug-drug interactions, but the HIV drug interactions and HEP drug interactions website from the University of Liverpool are great options. We've talked about the HEP drug interactions website here previously with drug-drug interactions, but there's actually a separate entity focusing on HIV as well. The next slide just highlights the interface and the access for that HEP drug interaction from the University of Liverpool. If you move on to the next slide, this highlights the interaction checker where the first column is the hepatitis drugs, and then co-medications can be selected from the second column, including HIV drug interactions. We move on to the next slide. Here, I just want to really reinforce that great news is that today, HIV hepatitis C co-infected persons should be treated and retreated the same as anybody else, including using the simplified guidance. We just need to pay attention to those drug-drug interactions, which leads me to my last bit. I'm just going to use a case to illustrate this for the group. If we move on to the next slide, Samuel's a 45-year-old man with HIV, CD4 counts 550, which is relatively preserved, and a viral load that is less than 20 copies per milliliter of blood, which is excellent control, who presents for hepatitis C evaluation. The person was previously treated with pegylated interferon ribavirin, but therapy was unsuccessful in the past. And workup reveals moderately elevated AST and ALT, platelet count that is technically in the within normal limits, but is on the low side of normal. A moderately elevated hepatitis C viral load, the genotype marked as genotype 2. This person had stage 2 fibrosis based on liver staging, and this person is treated with emtricitabine, tenofovir alafenamide, trade name Descovy, along with darunavir boosted with ritonavir, a HIV protease inhibitor with an older version of boosting medication, along with dolutegravir, a integrase inhibitor. So if we move into the next slide, this is just for something you to think about. What treatment strategy would be best? Would you use elbasvir grazoprevir for 12 weeks? Would you glecaprevir pabrentasvir for 8 weeks? Would you use sofosbuvir plus ribavirin for 24 weeks? Would you use sofosbuvir ladipsvir for 12 weeks? Would you use sofosbuvir velpatasvir for 12 weeks? You can think about it. We don't have this integrated into a specific poll. The reason I wrote these down specifically is just to kind of illustrate these were actually all options except for one of them that were recommended, or actually two of them that were specifically recommended in the past. I do want to highlight this as a hot topic question. We move to the next slide. I made this case and I specifically highlighted sidebar. I would probably use Softel in this case, and I'll show you why here in a minute. We move to the next slide. I specifically framed this as a person who got pegylated and ribavirin in the past. But if you were to use the IDSA AASLD guidance, you would actually go to the treatment naive bar. So I think I highlighted this in an animation. And you said, well, Cody, this person got treated before. If you actually go into the guidance document, I pulled out the text specifically that attributes this section. We move on to the next slide. This is what it says within the guidelines. Despite the enormous success of DA therapy, a small percent of patients who fail to achieve SVR with DA treatment will still require retreatment. To simplify and consolidate the guidance, this section no longer contains retreatment recommendations for interferon or interferon plus first-generation protease inhibitor failures because the cure rates with modern DA regimens in these populations are comparable to treatment-naive patients. In addition, pan-genotypic regimens with the addition of ribavirin have shown high efficacy for patients with prior failure across all genotypes. So what it boils down to, if people approach me and say, hey, Cody, this person got interferon or interferon plus this or interferon plus that on previous, and they were not cured, great news is you can treat that patient as if they were treatment naive based on our current regimens. So with that, even though this person has failed, quote unquote, a prior regimen, you can jump straight to treatment naive, straight to simplify guidance. But then we have to say, well, what do we have to think about for drug interactions? We move to the next slide. Remember, if you look at the IDSA guidelines, you could go to treatment naive, you can go down to genotype. You can say, oh, well, glycapropirensis for 8 weeks or sofosbuvir for 12 weeks are first-line regimens. If you use the simplified guidance, the same options would pop up. Next slide. This really highlights, well, what do we have to think about? And again, I buried an animation here. And these are the medicines that this person is taking. Ritonavir boosted darunavir, dolutegravir, and tenofovir alafenamide. If you work across those rows, you'll note that of our two options, sofosbuvir velpatasvir, there's a very limited impact between velpatasvir and darunavir, but no impact on dolutegravir, no significant impact on tenofovir alafenamide. But if you were to choose glycapropirensis, you would notice significant impacts on glycaprevir and darunavir. So this is an illustration of a hepatitis C protease inhibitor, glycaprevir, not mixing well with a HIV protease inhibitor, ritonavir boosted darunavir. Seems complicated, but again, if you use the University of Liverpool tool, you would find that alternatives, and this is just a great illustration of using a color-coded chart to help guide you whether you use the simplified guidance or whether you use the treatment-naive drop-down menus within the SSOD IDSA HCV guidance. Next slide. Take-home points here. HCV co-infection is a significant cause of morbidity and mortality in people with HIV. Drug-drug interactions between HIV antiretroviral therapy and the hepatitis C direct-acting antiviral therapy should be considered, but are absolutely manageable. And actually, effective and safe hepatitis C treatment for people with HIV is absolutely and necessarily selected. It's easy to do with the right tools that are available to you. With that, I think we've wrapped up this section. I do have my email available for questions if they come online, and I'll pitch it back to the group if there are follow-up questions for this section or to move us forward. Mia.
Yeah, thank you. Any questions or clarifications that anybody wanted to ask now before we move into our case presentation? Okay, if anyone thinks of any, don't hesitate to drop them in the chat or reach out.